You've been rubbing your left shoulder for a week. You assumed it was the way you slept, maybe the angle of your desk, maybe the fact that you skipped the gym and your muscles are tight. So you took ibuprofen, you stretched, you moved on. And not once did it cross your mind that your heart was slowly suffocating, because that's what's actually happening when a coronary artery narrows to the point where blood flow to your heart muscle drops below what it needs. The muscle doesn't just weaken, it starves. Oxygen delivery falls. Cellular metabolism shifts from aerobic to anaerobic. Lactic acid builds. And that starving tissue sends pain signals, not always to your chest, not always in the dramatic clutching motion you've seen on television, but often to your shoulder, your jaw, your upper back, referred pain. Your brain misinterpreting where the danger signal is coming from. And by the time the pain moves to your chest, the damage is often already done. Here's what most people don't understand about heart attacks. They don't just happen. They announce themselves. For weeks, sometimes a full month before the event, your body begins throwing signals, some obvious, some so subtle that you'd need to know what you're looking for to even notice them. And the problem isn't that these signals are invisible. The problem is that they look exactly like ordinary life. They look like being tired, like being stressed, like getting older. Today, I'm going to walk you through exactly what happens inside your cardiovascular system in the 30 days before a myocardial infarction, a heart attack. Not in vague, generalized terms, in specific mechanical terms. I'm going to show you the warning signs that cardiologists wish every patient recognized before they ended up in the emergency department. And I'm going to give you a framework for distinguishing these signs from the normal background noise of daily life. If you find this kind of evidence-based, no-nonsense health content valuable, the kind that respects your intelligence and gives you real clinical information instead of clickbait scare tactics, then subscribe to this channel right now. We're building a community of people who want to understand the machinery of their own body, and we're pushing toward 1 million strong. Every subscription means this kind of content reaches more people. And in the case of what I'm about to share with you, reaching even one more person could genuinely save a life. Let me tell you about a woman I'll call Maria. 51 years old, elementary school teacher. Active, she walked 3 miles every morning before work. No smoking history. Family history of heart disease, but she'd been told her cholesterol was borderline and was advised to watch her diet. That was the extent of the conversation. When Maria came to see me, she'd been experiencing what she described as episodes of tightness in her upper back, between her shoulder blades, that came on during her morning walks. Not every morning, maybe 3 or 4 times over the past 3 weeks. Each episode lasted about 5 minutes and resolved when she slowed down. She also mentioned that she'd been unusually tired, falling asleep on the couch by 8 o'clock, which was unlike her. She attributed both symptoms to stress, end of school year pressure. Her regular doctor had seen her 2 weeks prior for a routine visit and found nothing concerning. Blood pressure was normal. Heart sounded fine on the stethoscope. I ordered a stress echocardiogram. It revealed a significant area of reduced wall motion in the inferior segment of her left ventricle, the region supplied by the right coronary artery. A follow-up angiogram showed a 75% blockage. Maria was 3 weeks into what was very likely a crescendo pattern of unstable angina, a condition where the blood flow restriction worsens over time, and the risk of complete occlusion and full myocardial infarction increases with every passing day. She was one bad morning walk away from a heart attack. And the only reason we caught it was that she happened to mention the back tightness as an afterthought while discussing something else entirely. Maria's story is not unusual. It's typical. And the part that stays with me is that every single symptom she experienced, the back tightness, the fatigue, the exertional pattern, is textbook prodromal angina. It's described in the cardiology literature. It's been documented in studies published in the Journal of the American College of Cardiology. And yet, neither Maria nor her primary care physician connected the dots. Not because anyone was negligent, but because a standard 15-minute office visit isn't designed to catch subtle, intermittent symptoms that the patient herself has already dismissed as stress. That's the gap this video exists to fill. Let me explain what's physically happening inside your coronary arteries in the weeks before a heart attack. Because understanding the mechanism is what transforms a list of symptoms from something you'll forget by tomorrow into something you'll recognize in your own body. Your heart muscle, the myocardium, is supplied by 2 main coronary arteries, the left and the right, which branch from the aorta just above the aortic valve. These arteries sit on the surface of the heart and send smaller branches deep into the muscle tissue. The myocardium is one of the most metabolically active tissues in your body. It never rests. It beats roughly 100,000 times per day, and it consumes oxygen voraciously. Any interruption in that oxygen supply is felt almost immediately. Now, atherosclerosis, the buildup of plaque inside arterial walls, doesn't happen overnight. It develops over years, sometimes decades. Lipids, particularly oxidized LDL cholesterol, infiltrate the endothelial lining and accumulate in the vessel wall. The endothelium, when healthy, is a remarkably sophisticated barrier. It regulates blood flow, prevents inappropriate clotting, and manages inflammation. But when it's damaged by high blood pressure, elevated blood sugar, cigarette smoke, or chronic systemic inflammation, it becomes permeable. LDL particles slip through the damaged areas and lodge in the subendothelial space. Immune cells called macrophages arrive to clean up the lipids, but become overwhelmed, turning into foam cells. These foam cells cluster together, and smooth muscle cells migrate in, laying down collagen and forming a fibrous cap over the lipid core, creating what we call an atherosclerotic plaque. For a long time, this plaque may be stable. The artery narrows, but the cap holds, and blood continues to flow. Maybe not as freely as it should, but enough. The crisis begins when that plaque becomes unstable. The fibrous cap thins, inflammatory markers increase, enzymes called matrix metalloproteinases, secreted by immune cells within the plaque, begin to degrade the structural proteins holding the cap together. And when the cap erodes or ruptures, the contents of the plaque, lipids, cellular debris, inflammatory mediators, spill into the bloodstream. Your body treats this as a wound. Platelets rush to the site. The coagulation cascade activates. A clot forms directly on top of the ruptured plaque. And if that clot grows large enough to block the artery entirely, the tissue downstream is cut off from oxygen. That is a myocardial infarction. That is a heart attack. But here's the critical point. This process of plaque destabilization doesn't happen in a single moment. It unfolds over days to weeks. The plaque erodes gradually. Sometimes small clots form and dissolve repeatedly before a final occlusive clot takes hold. And during that period of instability, the heart is experiencing intermittent drops in blood flow, partial ischemia. Not enough to cause a full heart attack, but enough to produce symptoms. And those symptoms are your 30-day warning. Sign number 1. Unusual fatigue that is disproportionate to your activity level. This is the most commonly reported prodromal symptom of myocardial infarction, and it is especially prevalent in women. A landmark study published in Circulation, the Journal of the American Heart Association, surveyed women who had experienced heart attacks and found that 71% reported unusual fatigue in the weeks preceding the event. Not sleepiness exactly, more like a heaviness. An inability to do things that would normally require no effort. Climbing a flight of stairs feels like climbing 3. Carrying groceries feels exhausting. You might describe it as feeling drained, even after a full night's sleep. The mechanism is reduced cardiac output. When blood flow to the myocardium is compromised, the heart's pumping efficiency drops. Less blood is circulated with each beat. Less oxygen reaches your muscles and organs, and your body compensates by triggering fatigue. It's forcing you to slow down because the engine can't keep up. Sign number 2, chest pressure, tightness, or discomfort that comes on with exertion and resolves with rest. This is classic angina pectoris. It might not feel like pain. Many patients describe it as pressure, squeezing, or a heavy sensation. It might be in the center of your chest, or it might be slightly to the left. And here's the crucial point. In the prodromal phase, it often occurs only during physical activity or emotional stress, when the heart's demand for oxygen exceeds what the narrowed artery can deliver. When you rest, demand drops, supply catches up, and the sensation resolves. This pattern, exertional onset, rest relief, is the hallmark of stable angina transitioning toward instability. If you notice this pattern, you are not imagining it. Your coronary arteries are telling you that their reserve capacity is nearly exhausted. Sign number 3. Pain or discomfort in the jaw, neck, shoulders, arms, or upper back. This is referred pain, and it catches people off guard because they associate heart attacks exclusively with chest pain. The heart shares nerve pathways with these other regions through the thoracic sympathetic ganglia and the vagus nerve. When cardiac tissue is ischemic, the brain sometimes misinterprets the origin of the signal. Research published in the Journal of the American Heart Association has documented that jaw pain, left arm pain, and interscapular back pain are all recognized presentations of cardiac ischemia. If you're experiencing recurring pain in any of these locations that follows an exertional pattern, appears during activity or stress, resolves with rest, do not assume it's musculoskeletal until it's been properly evaluated. Sign number 4. Shortness of breath that is new or worsening. When the heart can't pump efficiently, blood begins to back up in the pulmonary circulation. The pressure in the pulmonary veins rises. Fluid begins to seep into the lung tissue. Not enough to cause visible pulmonary edema yet, but enough to reduce your gas exchange efficiency. You feel short of breath. This might happen during exertion, or it might happen when you lie flat, a symptom called orthopnea. You might find that you need an extra pillow at night, or that you wake up gasping. These are not signs of being out of shape. These are signs that your heart is struggling to maintain forward flow. The American College of Cardiology identifies new onset exertional dyspnea as a significant predictor of adverse cardiac events. Sign number 5. Sleep disturbances, including insomnia and sudden nighttime awakenings. In the same circulation study I referenced earlier, nearly half of the women who suffered heart attacks reported unusual sleep disturbances in the month before the event. The mechanism is thought to involve nocturnal ischemia, episodes of reduced blood flow to the heart that occur during sleep when blood pressure and heart rate fluctuate. These episodes can trigger sympathetic nervous system activation, a burst of adrenaline, which wakes you up. You don't feel chest pain, you just feel suddenly, inexplicably awake, alert, sometimes anxious. If you're waking up at 2 or 3 in the morning with a racing heart and a sense of unease, and this is a new pattern, it's worth paying attention to. Sign number 6. Digestive disturbances, including nausea, indigestion, or abdominal discomfort. The inferior wall of the heart sits directly above the diaphragm, close to the stomach. When this region experiences ischemia, the resulting vagal nerve stimulation can produce symptoms that feel indistinguishable from gastrointestinal distress. Nausea, bloating, a sense of fullness, heartburn that doesn't respond to antacids. Many patients, particularly women and people with diabetes, present with these symptoms as their primary complaint, and the cardiac origin is initially missed. If you're experiencing persistent digestive symptoms that don't correlate with what you've eaten, especially if they coincide with any other symptom on this list, the possibility of cardiac ischemia should be on the table. Sign number 7. Episodes of lightheadedness or dizziness. When cardiac output drops, one of the first systems affected is cerebral perfusion, blood flow to the brain. Your brain demands a constant high-volume supply of oxygenated blood, and when the heart can't deliver it, you feel lightheaded. You might feel faint standing up. You might have moments where the room seems to dim slightly. These episodes are your brain's way of telling you that the pump isn't keeping up with demand. In the context of other cardiac symptoms, lightheadedness is a significant red flag that warrants urgent evaluation. Sign number 8. Cold sweats or clammy skin without exertion. This symptom is driven by the sympathetic nervous system. When the heart is under ischemic stress, your body activates its fight or flight response. Adrenaline and norepinephrine surge. Blood flow is redirected from the skin to vital organs. You break into a cold, clammy sweat, not because you're hot, but because your body is in crisis mode. If you find yourself suddenly sweating without physical exertion or environmental cause, especially if it's accompanied by a feeling of impending doom or unease, this is a warning that should not be ignored. I want to pause here and ask you to do something. If you're watching this and you're over the age of 45, drop your age in the comments below. Here's why this matters clinically and not just for engagement. The biology of coronary artery disease genuinely shifts with age. Before menopause, women have relative cardioprotection from estrogen, which helps maintain endothelial function and favorable lipid profiles. After menopause, that protection disappears, and women's cardiac risk climbs rapidly, which is why the average age of first heart attack in women is about 72, compared to 65 in men, according to data from the American Heart Association. For men, the risk curve starts climbing earlier. By age 45, the cumulative burden of atherosclerosis in men with standard risk factors is already significant. And for anyone with diabetes, hypertension, or a strong family history of premature coronary disease, these timelines can accelerate by a decade or more. So tell me where you are. Because the urgency of what I'm sharing differs depending on your position in that biological timeline, and I want you to understand where you stand. Now let me give you something concrete, something free, something you can start doing today to assess and reduce your risk. This is a home monitoring protocol grounded in established cardiovascular medicine. Step 1. Track your resting heart rate every morning. Before you get out of bed, before you check your phone, before you do anything, count your pulse for 60 seconds, or use a pulse oximeter, which costs about $15. Write it down. Do this every day for 2 weeks. You're establishing your personal baseline. A healthy resting heart rate is typically between 60 and 100 beats per minute, but what matters most is your trend. If your resting heart rate is gradually increasing, climbing from 68 to 74 to 80 over 2 weeks, without changes in exercise, caffeine, or stress, that can indicate increasing sympathetic activation. Your heart is working harder to maintain the same output. That's a signal. Step 2. Perform a functional exertion test on yourself weekly. This is not a formal cardiac stress test, but it's a practical self-assessment. Choose a physical task that you can reproduce consistently. Climbing 2 flights of stairs, walking briskly for 10 minutes, carrying your groceries from the car. Note how it feels each week. Can you complete it at the same pace? Are you more winded than last week? Do you need to stop and rest where you didn't before? Any progressive decline in exertional capacity, being able to do less with more effort, is a warning sign that deserves medical evaluation. The European Society of Cardiology recognizes declining exercise tolerance as one of the earliest and most reliable clinical indicators of worsening cardiac function. Step 3. Know your numbers. If you don't know your current blood pressure, fasting glucose, hemoglobin A1C, and lipid panel, schedule a blood draw this week. These 4 data points together create a reasonably complete picture of your cardiovascular risk profile. Your LDL cholesterol tells you about the atherogenic burden, how much lipid is available to infiltrate your artery walls. Your triglycerides and HDL ratio gives you a window into metabolic function. Your blood pressure tells you how much mechanical stress your arteries are enduring with every heartbeat. And your glucose and A1C tell you whether glycation is actively damaging your endothelium. You can't manage what you don't measure. And in cardiology, the difference between a managed risk factor and an unmanaged one is often the difference between a normal life and a catastrophic event. Step 4. Learn the difference between stable symptoms and unstable symptoms. This distinction could save your life. Stable angina follows a predictable pattern. It comes on with exertion, it resolves with rest, and the threshold stays consistent. You get chest tightness at the top of the stairs every time, and it goes away after 2 minutes of sitting. That's concerning, but it's predictable. Unstable angina is when that pattern changes. The symptoms come on with less exertion than before, or they come on at rest, or they last longer before resolving, or the intensity increases. Any change in the pattern of symptoms, what cardiologists call a crescendo pattern, is a medical emergency. It means the plaque is actively destabilizing. The artery is closer to full occlusion, and the window for intervention is narrowing. If your symptoms change, you don't wait for your next appointment. You go to the emergency department that day. Step 5. Aspirin protocol awareness. There's a common belief that taking an aspirin during a heart attack can save your life, and the evidence does support this. Chewing a regular dose aspirin during an acute myocardial infarction helps inhibit platelet aggregation and can reduce clot growth. The American Heart Association recommends chewing 1 regular strength aspirin at the onset of suspected cardiac symptoms while waiting for emergency services. But here's what I want to be clear about. This is an emergency intervention, not a prevention strategy for everyone. Daily low-dose aspirin for primary prevention, meaning in people who haven't had a cardiac event, is no longer universally recommended. The United States Preventive Services Task Force updated its guidelines based on evidence showing that the bleeding risk of daily aspirin outweighs the benefit for many individuals. Whether daily aspirin is appropriate for you depends on your specific risk profile, and that's a conversation to have with your physician. But knowing that chewing an aspirin during acute symptoms is a validated emergency measure, that's knowledge worth having. Let me bring this back to what matters. What I've described to you today, the fatigue, the shoulder pain, the subtle breathlessness, the sleep disruptions, the cold sweats, these are not random symptoms. They are the physiological consequences of a coronary artery that is losing its battle against an unstable plaque. They are your body's 30-day warning system. And the tragedy, the preventable tragedy, is that most people who experience heart attacks had these warning signs and did nothing. Not because they were irresponsible, not because they didn't care about their health, but because nobody ever told them what to look for. A study in the European Journal of Cardiovascular Nursing found that the average person experiencing prodromal symptoms of myocardial infarction waits more than 5 hours before seeking medical attention after acute symptoms begin. 5 hours. And among those who reported prodromal symptoms in the preceding weeks, the majority had attributed them to non-cardiac causes: stress, aging, poor sleep, muscle strain. Every hour of delay reduces the amount of viable heart muscle that can be salvaged. Every hour. You don't have to be a victim of that delay. You have the information now. You know the signs. You know that exertional chest pressure is not normal aging. You know that unexplained fatigue lasting weeks deserves investigation, not acceptance. You know that jaw pain and back tightness in an exertional pattern could be your heart. And you know that when a stable symptom pattern starts changing, getting worse, lasting longer, requiring less effort to trigger, that is the moment to act. Your health is your responsibility, not the pharmacy's. I'll see you in the next video.